I am your Katie. You're joking in today. She's not able to make it today. And then Co-Chair Bradley also got pulled away for some physician related things. Can you believe that? So today it's our August meeting, and we have a couple things on the agenda. Those are our welcome and roll call, some director's updates from Director Dolph, agency partner presentation about the ASAM4 implementation, and a conversation that was kind of an ongoing matter about shoring up what discharge and transition standards could look like for the state of Oregon as it relates to substance use care. Given that we'll have a lower level of attendance today, I do anticipate that this will kind of be a part 2.5 in addition to probably returning to this in September just to make sure that we've had everybody weigh in. But for all of that, Ashley, would you like to do roll call? And I'll stop sharing.
Yeah. Hi, everybody. Happy Wednesday. We'll run through roll really quick. So if you're here, please say present. Moxie, are you here today? Okay. I do not see Moxie. Christy?
I'm here.
Hi. Heather?
Present.
Thank you. Mike?
I'm here.
Thank you. Amy?
Present.
Thank you. Allison?
Present.
Thank you. Lisa?
Here.
Thank you. And Beth?
Beth is one of our
should
late
be- yeah, she
arrivals, I
should be
believe.
Did I miss anybody? Is anybody here that I did not call?
I'm here as well.
Becky? Thank you. Okay, back to you, Mitch. We have not hit quorum yet.
No problem. And over to you, Director Dolph.
Thanks, Mitch. Annalise Staub. I'm the director at the Alcohol and Drug Policy Commission. Run through my usual announcements. Hopefully, for the folks who aren't here, they'll watch the video soon. So the commission actually took this month off. I don't think any of the committees did, but the commission took off August. We will be back in September, and we'll be spending our time on the substance use disorder state agency financial assessment that we've spent a good part of the past 6 months doing. I realized I hadn't talked to Mitch about this, but I think most of the committees will probably be doing some kind of deeper dives into what we've gathered in the coming months. Particularly with treatment, I will just flag that one because it's these gigantic numbers through Medicaid with not a lot of detail, but thanks to Mitch and the team at OHA, there is quite a bit of detail behind that we can learn from. Oh yeah, the Oregon Youth Addiction Alliance also meets today. They are continuing their work in conjunction with the recovery committee to spell out best practices for recovery community centers that serve youth. There's also an upcoming youth summit happening that several of our youth are taking part in, and so they've been talking about that a lot. Recovery meets next week, and I believe they're going to continue talking and maybe wrap up the Recovery Community Center youth best practices language. And then they are working on a concept to do a Recovery Community Center report using that definition, identifying the RCCs in the state, and starting to come up with maybe some surveys, some ways to document the work and the outcomes that they're doing. Health, Safety, and Interventions also meets later in the month. Senator Reynolds, who's one of our commissioners, is going to be bringing her syringe service program legislation to the committee to get some feedback. And they will also be continuing their conversation and work around a naloxone toolkit. So that's something I think that'll be a resource to everyone, but particularly for this committee, just to put that out there, that's one of the places, one of the tools, if you will, that they've decided for implementation to really have kind of a one-stop shop where we're not duplicating what's elsewhere, but so entities can very quickly see, okay, this is where I go to get the cheapest naloxone. Here's kind of best practices. Here's some model policies. particularly, they're working on developing some policies around soon to expire naloxone. So that's pretty cool. And prevention, the primary prevention committee also meets the last week of the month, and they will be going over kind of what we call loosely the House Bill 3321 report. In 2025, there was legislation directing the ADPC to do an assessment of primary prevention in the state. It's actually kind of a sub of the bigger financial assessment, but a deeper dive. And they're going to be going over that at their next meeting, which is pretty exciting. And then finally, I'll just give a quick update on the opioid settlement board. For those of you that are involved locally with local settlement spending, it is reporting season. So if you have any obligations there, please make sure that reports are coming in to DOJ. That's how we really track statewide where the money's going. This month, we finalized recommendations to OHA for an RFGA that will be posted this fall. So the expectation is they're going to do one round of funding. We were able to work with OHA to design a process that will really focus the approved uses of settlement funding that align with the comprehensive plan. So we're really excited to see what comes out of that. And as those links become available, et cetera, we'll make sure everyone in our orbit has that. And then in September, the settlement board will be meeting for some updates and also to hear a proposal to perhaps allocate some resources to support some work we're loosely calling mapping recovery that Mitch is really a part of to start to move us forward on a substance use disorder data system. So lots of exciting stuff. That's my update. Happy to answer any questions. Thank you.
Thanks, Annalise. I don't know why I always like default to the director Dolph. It feels so unnatural every time I do it too. Next we have Amanda Braxton, who I'm really excited is coming from our Medicaid division. Amanda's been a really great collaborator and partner with me over the last year as we've been kind of chatting about ASAM, and I'm just really excited for her to be able to have an opportunity to come speak with the treatment committee, for you to ask questions and really kind of get this high level overview of like what this transition could look like. And then the hope is later in the fall, another member of Amanda's team will kind of come talk more in the nuts and bolts too. So this isn't something that is going to be a one-time. This is something I know we've talked a lot about here. And so Amanda, thank you so much for being here, and I'll be quiet and turn it over to you.
All right. Thank you, Mitch. And I just want to make sure I am sharing the slides and not my notes or another screen or my emails. Okay, good. So I'm Amanda Braxton. I'm an operations analyst under the Medicaid division, but I'm here today representing both Medicaid and Behavioral Health Division as the project manager for the ASAM4 transition project. And so we started meeting together, probably about 8 months ago. And I have two people in our team that are here today just listening in. So I just want to let them know they can jump in if they want or they don't have to. But what we've been trying to work on is transitioning from the ASAM, American Society of Addiction Medicine, third edition to the fourth edition, particularly around rules. So we are, I'm basically coming in today just to talk about our direction in the rule writing and what we're going to do before we start rule writing, and let you know what the timeline will be and how others can engage in the work. And also, I just want folks to know that please feel free to interrupt. I did design these slides to be 10 minutes long, and I have 20 minutes to speak, so folks can interrupt if they'd like. So like I said, we've been meeting since November as kind of a project team. Been discussing it probably for years, but we've been meeting officially and making official plans and directions since November, focusing on updating Oregon administrative rules, evaluating payment models, and within the Medicaid division, and then how we're going to develop policy guidance support implementation. And we do have a memo out there that providers should be compliant or implementing ASAM4 by July 1st. We're going to be sending another memo out in a couple of weeks, changing that timeline to January 1st, 2028. It aligns well with a lot of our our payment things that we're doing on this on another project work stream. And also it gives us some time to engage providers the way we would like to. So I'll be going over that timeline and how we can engage. But first I want to share kind of the direction we are going in rules. We talked about several avenues, but we landed on this, just looking at all the rules, conducting a full analysis, all the rules for Chapter 309, Divisions 18 and 19, and deciding what is essential in the rule and what is not essential. So what's for informational purposes, removing that, and looking at it from an administrative burden perspective. And my next slide I'm going to share here, we'll talk about what is essential from our viewpoint. And this slide, I'm not going to read all the text because it's a lot of text, but it's something that we can all look back to when we're looking at what OHA is going to do in rule. This is kind of our guiding slide for us, and hopefully it can be one for all of you too. It is a public document, so I felt like not the slide itself, but our standards, terms, and conditions is a public document, so I felt comfortable sharing it in this meeting. There's a link here if you're one of those who like to read 120-page contracts or plans, it's right there, but I prefer not to. So Medicaid helped develop this really neat slide with the 9 core elements that we're going to lead us through the work that we're doing. And so this is from the 1115 SUD waiver. This is what is required for us that we have promised our federal partner, CMS, to do. And it specifically talks about keeping these things in our Divisions 18 and 19 rules. So these slides are available, but if you lose those slides, feel free to give me a call and I'll send you this link. Actually, maybe I'll pop this. Mitch, you want to pop that link in for me?
No problem.
For the standards, terms and conditions link. But at the same time, while go ahead, Heather.
Hey, Amanda. Sorry, I just apologies
back.
for interrupting.
No problem.
There was, when I'm looking at 3, 4, 5, and 6, there was a lot of feedback about ensuring that the way the rule, there was a lot of feedback when we first went through this journey a couple years ago about removing as much stop and start between levels of care as we could. As hopefully those of you who were there with me, that's a good way to say it. Because the way the rule is written now, there's hard stops and starts at every level of care. And ASAM really wasn't written to be implemented that way. And our rule required us to operationalize that way. So I just ask as you're going through that, because that's very administratively burdensome for providers, and actually does cause a lot of extra reporting for other folks involved in the system also at the OHA level and the CCO payer level. And so if there's a way to take a look at that, and there was a lot of feedback given on that about how options or things to try and do about that. And I wouldn't want that work and feedback to get lost. So
Okay. And so when you were meeting with folks, was it through the ASAM 3 engagement or through Mitch?
It was prior to Mitch.
Okay.
It was when we did the original ASAM, and I'll be frank, it was not a pleasant experience. And there was a ton of really valuable feedback given through almost weekly and sometimes multi-weekly meetings. Allison has got her hand up. She can speak to that because her teams participated in that. And it was talking about both 3 and 4, because we all knew 4 was 4 actually was implemented while we were working on 3, which was also a bone of contention for folks, but I won't go there. But I just did, sorry. So,
That's okay.
So I just want to make sure, as we're talking about engaging providers, even though this was a few years ago, it is very fresh in people's minds, because it was a very unpleasant experience.
And I want to just kind of confirm what you said. And I was sneaking around ASAM 3 files today. And so maybe I'll find those notes because there's plenty of notes in there. And I'll look for that information and
Yeah,
include
and
it
then
in
there's
our
people in this
material.
committee who participate,
Mm.
include more than just me. There was lots of people, and I'm happy
Mhm.
to be a historian if I could be a help to the team.
That sounds
Thank you.
good. Thank you. Go ahead, Allison.
Yeah, a little bit of just to emphasize a little bit of what Heather said. She's referencing the advisory committees that were convened for the rural updates when we implemented we implemented ASAM. So I guess lots of things to think about and say. But before I do, the numbers also that Heather's referencing 3, 4, 5, and 6 could leave lots and lots of room for interpretation. Like they're pretty
Mhm.
simple lines and big categories of potential content. So I guess my question in thinking about how this went down the last time was like, are these 1 through 9 items, is this literally how CMS has written it in their guidance to us or to
It's
OHA, or is this OHA's, forgive me, interpretation
Mhm.
of what CMS has told them they need to do?
It was a work plan that was created a couple years ago. So it's our commitment we sent to them and signed off on.
Okay.
Yeah,
This, so like, and forgive me for being
for the
ham-handed.
1115 SUD waiver.
So word for word, this is what we sent to
Mhm.
CMS.
Yeah,
And they said yes, okay.
yes.
Because again, like, and then there's just there's potentially a lot of room for content in those numbers.
Mhm.
And it's where things got very challenging the last time. And I'm happy to be a productive participant again. If you do not know already, as Heather's referencing, you're gonna run up against a lot of people who had
Mhm.
some pretty
I
tough.
I'm well aware of that. When I announced that we were starting a project in October, I had a few of those phone calls.
I'm
And
sorry.
quite nice. I mean, but just, the history, folks sharing the history, among other things too. Um, Go ahead.
Maybe just like one like concrete thing that
Mhm.
could go forward is, I think one thing that really befuddled us during the last one was why the OAR, or why our rules, the OARs couldn't be written to reference the most current version of ASAM versus they literally called out the last version of ASAM, and we all kept saying like, but it's gonna get updated. Why can't we be less prescriptive and more overt about pointing to the most current
Yeah.
version? And so
And so I think Luann, she's going to be the rule writer come this go around, and she has kind of the same ideas around flexibility. So we're not having to completely rewrite the rules every time there's a new ASAM 5 or 6 comes around. Just adding the important stuff to it. So I think she's of that mind, and that's kind of why we're going in this direction where we're engaging, where we've decided to engage folks first before we write the rules, start writing the rules. And so Luann will be here in October, so you can have some of those philosophical conversations with her, because I don't want to put words in her mouth. But she enjoys having those conversations. So, but I have a feeling that's the direction she's going in. But it was a good segue into this. While we're looking at what we are required to do through our federal partners through that STC standard contract, we do want to we want to be flexible. But we want to have this balance so we ensure quality care and safety of our patients and members. So while we're looking at what's essential, we're also going to look at how we can ensure that we're not overly prescriptive, but not overly broad either, because we want to maintain the safety and quality of the care. So we want to find that balance of being somewhat prescriptive, but also flexible, but not too broad. So it's just kind of giving that creative license there, that disclaimer there. For our timeline, just very basic. We decided we were starting to write the rules in May, then we decided to start, maybe we need to get some information from folks first before we get into this very deep dive into the rules. So I'm hoping we'll have our memo approved and all our questions approved by the end of this month, and then we can start scheduling meetings in September. But we'll be going through fall and winter through December, meeting with folks through varying avenues or collecting data from folks. If they don't want to come to a meeting, we have other avenues they can do. And then finalizing those rules in May, but not publishing them yet because then they have to be approved by leadership, go through the DOJ and all that stuff, all the checks and balances, maybe tribal engagement, things like that. But we hope to have the final rules in May and then have those published in July. Which leads us to why provider compliance in January, because we want to give them those 6 months to kind of understand what's out there and what they need to do on their end. So this is kind of a brief outline. Lou Anna are going to meet to kind of get the dates together. We hope to have in-person and remote meetings. The leadership did approve the in-person meetings, but we are kind of in a budgetary constraints and we did not talk dollars. So we're going to talk about traveling and doing in-person meetings, but it might be not as large of an in-person amount of in-person time as we would have liked. But we're definitely going to have remote meetings and then individual provider meetings on request. And then we have a feedback form since November. It's been out there. There's the link there. It's also on our the website. Maybe I'll provide those links after these slides. If you have feedback that you want to share today, go ahead and you can email me or talk about it today. But there's also this form. It goes into the central location. If you email me, that's where I enter it into. And then we're going to have a survey, a questionnaire, very long. But the survey is more about having a list of questions to bring to providers at those remote and in-person meetings rather than just opening up a meeting and say, hey, you want to talk, having a listening session, kind of a guided listening session. So the goal is by end of the year is to have data to report to leadership on common themes, opportunities, challenges, and best practices that come up among the providers. So the next step for our team is to finalize those feedback questions with the project team. And then once we have that going, we have our website and some of the dates aligned in the website, then send out a memo to let folks know how they can engage in this work. But we want to have everything kind of aligned on the website before we send that memo out and have it approved by leadership too. How am I doing on time, Mitch? Am I good?
You've got time.
Okay, good. Go ahead, Moxie.
Hi there. I work in an opioid treatment program, so we give people methadone, and I've worked with buprenorphine patients for a really long time. One of the major challenges and really heartbreaking situations that I come across is that patients are told that they can't be on methadone or they can't be on this current dose of methadone and they have to taper if they go into inpatient withdrawal management or if they go into residential. And so I like that protection. I think it was number 7 on the slide you showed that says that they have to accept people taking these medications. I would really appreciate it if they also had to be required to follow the provider's prescription and their treatment plan while the patient's there. What I see happening is often patients might be on 150 or 180 milligrams of methadone, and then whoever is the medical director at the facility has no experience with methadone, and they start telling me what I have to do with their dose. So they'll do things like, you can come here, But before you get here, you have to taper to 120 or 130 milligrams. And so they're using fentanyl with 150 or 180 of methadone. They're told you have to taper, which makes no sense if it's already failing to help at the current dose. What we'd really like to do is be allowed to have them admitted, increase the dose while they're there when they're off the fentanyl. And a lot of patients don't understand the importance of the medication. So they think it'll be somehow magical that they're going to go to a program for 1 month and learn a bunch of behavior changes and not need the medication anymore. And so we frequently see them come out and use a lot more than when they went in. Because they're not protected by that dose. So whatever we can do to protect the dose and the medication and control of the dose while they're there would be really helpful. Thank you.
Thank you. Go ahead, Heather.
Thanks, Moxie, for bringing that up. And I agree, because I think sometimes even there's pressure and recommendation to change to other types of medication and without coordination with the treating methadone provider, which is not okay either. The thing I wanted to bring up is there a process here to align that with the CCO 410? That was something that was brought up. That piece really just wasn't addressed. And so hopefully this roll around, there will be some appropriate adjustments for CCOs, because one of the things that we found is, even though Oregon's been an ASAM state for many, many decades in different iterations and forms, some of the CCO partners require other assessment tools besides ASAM, and that becomes really administratively burdensome and a little weird when the state is requiring providers to use one tool, and then CCOs can choose to use other tools, and then you're having to assess a patient, a consumer with two tools. That's not trauma informed. It's not administratively effective. So all those things. So we just ask. I just want to bring that up again. That was a really important item that I don't see reflected here.
Can I make a comment real quick, just to see kind of how you respond to it?
Yeah.
So I looked at the 410 rules, and most of the rules refer back to Chapter 309. And so is that causing problems?
I don't, for whatever reason, it is not clear enough, or
Yeah.
perhaps it is not clear enough, or carrot incentivized or stick incentivized enough that CCOs will accept what providers are required to do.
Thank you.
Yeah, so I appreciate that. So I still believe that there is a clarity issue around that.
All right. That was great discussion to start off our engagement. So I really appreciate it. You were the first folks. Well, I did engage another team in December, but you're the first after I knew what I was talking about. I know what you're talking about now. It's not all just acronyms and mumbo jumbo. So I really appreciate your feedback, and it'll be the first in our chart. Thank you. Thank you for inviting me, Mitch.
Yeah, of course. Thanks for being here. And something that I really would like to impress upon you all. Also, I see your hand, Allison. That feedback form, like, please use it. I've been sort of like overjoyed the amount of times that I've been in conversation with Amanda, and either something philosophically has come up in this committee or has come up in the conversations between Amanda, Luann, and I, and then seeing those things like end up in the list of things to tackle or discuss, like, has just been really cool to see that process. So I just want to give a shout out for that.
Thank you, Mitch. And just so you know, just because it ends up on the feedback form doesn't mean it's going to be tackled, but it's like a theme. We're trying to see what to prioritize. So put your things in there so we could start seeing that theme and prioritize that work too. So it's important, even if it's something small. Go ahead, Allison.
Just a super quick logistical question. I'm looking at the feedback form and the landing page on the OHA website. Is the feedback form the only way to get on the email notification list? I don't see it on the website.
So does the feedback form not allow you? Hold on, let me exit out of my presentation
Oh, no,
here.
it does. It's just like if I didn't have actual feedback, I just
Oh,
wanted.
yes. Yeah, there's an email. Yes. And so I need to put that on the I'll put that on the website too if they want to submit their email. Thank you. I didn't realize I didn't put the email form in there too.
Awesome, thank you.
Mhm. Yeah. I'll add that link this week.
Are there any other processes for just like and I know this was like very high level, very early, but I just wanted you folks to have like visibility on how this was going to be happening over the next years because it's become such a focal point. Does anybody have any questions about the timeline or process or any of those things? I just wanted to also say, Amanda, I don't, because you were in presentation mode, the amount of like relief, excitement, and celebration I saw when the concept of like we're trying to understand what is necessary versus what is not. So I just wanted to say like that was something I could see if you did not.
Thank you. I'm gonna put all the links in the chat of the forms, the website, and things so you can refer to it and not have to pull up. But yeah, I'll hang out a little bit and then I might leave in about half an hour. Thank you everyone
Thanks for being here.
inviting me. Mhm.
Cool. And not just because I like things to be so perfect. That is a great setup to what we are doing next in the committee, which is talking about our kind of standards and discharge goals, or for the standardization of transitions and discharge. Just getting my slides back up. The reason that I think that this is kind of a timely thing, you might remember some similar language from that slide that Amanda just shared about the CMS requirements or what our agreement in our STC is. That was really like where this original kind of conversation came of having Amanda is saying like, hey, we're talking about discharge and transitions, and it feels very much like we can't separate those out from the ASAM conversation. And so I would I'll show the list of questions in a little bit, but one of the things that I really want us to wrestle with as we start to talk through this today is why doesn't this happen now? Because I think to the point about the conversation around medication access, like is it an enforcement problem? Is it an incentive problem? Like those are those things that I think we'll really have to start to be specific about in our recommendations and our asks and which policy lever we'll be spending the most time in. So just kind of queuing that up there. So a little bit of a reminder of how we got here. I think this was back in April. We had this conversation around like prioritizing the bunch of things that this committee wants to focus on and started to delegate things to work groups and decided what to keep in committee. One of the things that we talked about was this problem that we have where there's a rate of programs that we hope to see have a standardized discharge planning in the future, but we know that there's an inconsistency. So we talked about there's a possibility of coming up with the standards here, but also embedding a lot of our questions and needs in that provider survey. I believe Third Horizon should be back in September to talk through us about their kind of initial draft of that. So just know that that's still happening in the background, but it's the summer. So everybody's kind of doing the bajillion things. And one of their bajillion things is that prevention study that Annalise mentioned earlier. So while I kind of go through the themes that I gathered out of our last meeting, as well as like kind of a standard block of draft text, I'm imagining we're going to do a lot of different things with that. Things that I would like you to think about. Anything that's been missing. And I say missing in terms of stuff that maybe you mentioned that I missed, or things that we wish we had said or covered, or where this is maybe we just didn't think about some sort of complexity or population that we should have been thinking about. What isn't captured with the correct intent? Maybe somebody said admin burden and I mistook that as paperwork. I didn't, but just use that as an example. How is this different from the current standard? And if it isn't, that's an okay thing too, but like, why is that here? And then the biggest thing is what prevents that from happening now. So, and I'll add like a little what prevents that from happening now, or what maybe also encourages the thing we're trying to stop from happening to continue to happen, I guess. So first theme that I think was probably the largest theme as we talked through the hopes and dreams and challenges and transitions for this future standardization is that this needed to be person-centered. And I think we've talked about this for folks that aren't aware or involved. In the evidence-based practice work group, one of the conversations that we've been going around with is like this difference of what it means to say we do person-centered care or individualized care versus like what it actually is to do. I was talking with somebody from OHA a couple hours ago, and they mentioned like this. We were talking through the when individualized service plans came on, like I think a lot of excitement happened, and then we dealt or experienced the shift to electronic health records, and those paper forms felt a lot less fluid suddenly. And so like there's things that maybe even in the system that have kind of caused this, but in general, what we said about person-centered and needs-driven, at least what I took away from the conversation, is that that meant planning begins at admission. It's continuous, and it's a result of identification of needs, strengths, preferences, and recovery goals. Participants are active decision makers in their own care, and it includes specific recovery management and relapse prevention tools that are relevant to the goals. For full transparency, the recovery management language, I don't think we talked about here, but I did take from ASAM 4 language because that is this kind of new branch of our continuum that they've been talking about. When we talk about person-centered or needs-driven, is this what you are all describing, feeling, thinking, or is there something else that's missing?
I'll just say, I mean, I think it does largely, it was a good discussion. I liked it, and I think this captures it. I think what happens with phrases like person-centered that we sort of use and see all the time, it's like when it comes down to like, what does that actually look like? It sort of becomes like, well, I was nice to the person when they were here, right? So, I mean, I think well, I think in our last meeting, sort of loudly spoken, and I don't know if there's a way to sort of hold this more emphatically forward. It's like, it's really about the part that feels really important is it's not the provider telling the patient what the end state of their recovery needs to be, right? So I think there's potentially room to just wordsmith this to get it even sharper. That is about tolerance for a recovery goal and preference that isn't exclusively abstinence oriented. So just again, because I think this leaves the right room, and everybody goes, "Oh, of course I'm person centered," but I think I've said it enough.
I just realized if anybody's hearing me typing my notes, I'm sorry, I went to unmute and realized I'm not muted. Thank you for Zoom for hiding my buttons. I will think about kind of like what a bullet point for this, but I did write down like specifically like tolerance for a recovery goal that is not explicitly absent oriented. Like I'm imagining that feels like the continued sentence to that last bullet point of like the why there is like what that's seeking to do as well. Because I think otherwise, like people would say like why recovery management versus relapse prevention. I'm remembering Dr. Melee years ago saying like where's the problem prevention plans and why is everybody getting relapse prevention plans? So in that same vein. Other thoughts for like person-centered, needs-driven? I also, you'll notice I'm driving slides today, and that was because I told Ashley like I'm anticipating we'll do a lot of back and forth, and so if you need me to go back to a slide or whatever, please let me know that too. Okay, the next thing was planned, structured, and standardized. Standardized is I felt a little silly putting it because it was like defining the word with the word, but we said we were going to standardize it. However, what we said is they're intentional processes, not administrative events. And so that's something that I do think I'll just flag that I think we'll probably have to have this like other conversation about like what do we do in those terms where it is an administrative event and like why is that and a bunch of stuff there. Standardization helps ensure equity, reduces arbitrary programmatic rules, and preserves the balance of clinical flexibility and rigid regulation, which I think, like, in my head, we were going, I had borrowed a slide from Amanda from last month. You might have seen that come back of that scale. And I think that's something that I know we're going to really probably wrestle with for a little bit of like, if we're coming in to say, like, here's what a lot of care should look like how do we do that in a way that isn't scary, impossible, expensive, too expensive, all of those things. And then also that we should be avoiding a checkbox style compliance while also still maintaining clear minimum requirements. So like what does that floor look like of care, but also like what are we seeking to do as well? What is missing? What are you liking, not liking? What's different about this from like current standards? Yeah. This is the very this like felt like a very aspirational slide to me when I was writing it out. Seeing nods feels ish. Okay. Again, let me know when to come back. I'm gonna work through these just to keep us moving. Clear distinction between a discharge and a transition was something that we also talked about. These are like two separate events, but I kept finding myself wondering like how do you plan for both, like, or how do we support the planning for both? And the way that this was described here was transition implies a movement within the continuum, so moving from residential to outpatient, whereas discharge was mentioned as an end or termination of services at that level of care. So one question I was curious is like, was this group considering that a discharge means you're leaving with no further care, or are we thinking back, for those of you that are a little bit more acquainted with ASAM4, are we thinking that you're left with adequate care, which implies social supports and environmental supports are sufficient? Like what is it that is different about those two things? Those were the kind of like things that I pulled out of the conversation. There was also this desire, you'll see my little asterisk there, to talk about where UM or utilization management derived transitions are happening. Something that I think that we definitely have been hearing a lot more of is like this happening as I think like financial problems are starting to occur. But I'm curious, like, if that in itself is a third column, if there's like a fourth, like what is it that we're also seeking? Like, and that really came from this group and why we would be doing that or what the mechanism would be. So thoughts for this topic or the specific theme, I mean. Go ahead, Heather.
I think, thank you for putting that one on there. And I do think it's an important one to track. And I mean, I could rattle off a couple scenarios under that one. So I think there's opportunities to track some system trends there at the systemic high level, and especially because Medicaid is a state plan. So I think it's good to be tracking those things. And I think what we're seeing already is shortened stays that are not the same as the clinical assessment, being care not authorized or referred to the most appropriate setting because the most appropriate setting is a different cost or availability. Sadly, the one we're seeing this happen is parenting programs. It's really unfortunate, but we're seeing that in some parts of the state. So I think those are the kinds of, so somebody could be referred to an adult only program, right? And that's going to be a different cost, a different type of treatment, not necessarily getting approved to go to a generally appropriately more services, more specific for a parenting program. So that is happening in some parts of the state. So I think capturing those kinds of trends across the plan is really important, and having a way to kind of share how that plays out is really important. So I appreciate it.
Real quick before you chime in, Allison, one thing that I just wanted to flag for folks that exists with an ASAM is there's like the 9 reasons that a level of care could differ from the recommended. And like I wonder if that's just one of those like nice things or opportunity to bring in with like this transition point of like alignment of ASAM4 with like what's being tracked in that probably part of roads or something, because I think we basically have 3 or something in there. But go ahead, Allison.
I think you were getting it because I think there's a whether or not it's it'd be interesting if it was UM related, but there is, I think, where there should be an opportunity to acknowledge when a transition, the sort of the other end of the transition is what it is because what is recommended isn't available or isn't authorized. I think those are two different things. They will be worth acknowledging. So it's sort of like there's this UM like sub bullet. It's not its own category, but it would be delightful to kind of understand when it is linked, like when it is driving either a transition or a discharge. And so that might be getting too kind of complicated and to get into like meaningful data that can be tracked, but I think it's compelling. But regardless, I love the idea of having a data point that is like, this is because treatment is authorized or because treatment couldn't get paid for in the next place. There was whether or not you intended it, Mitch, when you were kind of describing the discharge bullet point. I also think it's important to differentiate from a transition. There are plenty of reasons people discharge from facility-based care or even, other OTPs and outpatient too for any number of reasons. But I don't want to let people off the hook for attempting some version of discharge planning, even if you have to discharge people. So I think you said something about like a discharge means there's no plan, and honestly, rarely there is because that's just what happens. But I'm a little nervous about saying like, if you had an opportunity, you should still try to figure out, even if you're ejecting that person from your program for a behavioral problem, like, you should still probably try to find a place for them to go.
I don't remember the last time that I've used this term, and I always feel silly as not a parent, but I always like to use the like what to expect when you're expecting title. And like, I'm kind of wondering though, like if you're almost describing a need, because we've said already that this is continuous throughout. I'm wondering if there's like an opportunity for this to be. I hesitate to use the phrase stage specific because I think then people get locked into like another programmatic version of care. But I do sort of wonder if there's like a relevant planning for like if you just tomorrow woke up and decided I'm out, like what are the supports that you have available to use to support you tomorrow? Like it almost feels like creating this as this continuous like plan kind of sets you up to always have a backup discharge plan or something.
And we were touching on something similar to that. If you go back to the
Okay.
slide that was talking about discharge planning starts from the beginning. There's that where you've referenced recovery management and relapse prevention supports. We were starting to touch on those as sort of like almost like a crisis plan.
Mhm.
Right. So it's not just like when things are hunky-dory and you leave here and you've completed treatment and accomplished all your goals, here's what you want to have next. There was that, and let's talk about what happens when things go sideways so that we can keep you safe, so that we're lowering your risk of, unintentional overdose or whatever. Like, let's talk about this like it's a crisis plan while you're not in a crisis. I mean, that is the time that you put together a crisis plan, is when they're kind of safe and protected, and gives people permission and space to talk about when things aren't, what to do when things don't go well. And I just, as a former crisis worker, I feel really strongly about normalizing those conversations.
This is probably too optimistic, but that almost feels like a neat way of sort of bringing together the worlds of mental health and SUD a little closer also, though, to just be like, this is a thing we all do. Like we're planning for the worst, hoping for the best, but doing it now in the off chance that we need it, right? Just checking before I move on to the next theme. Are there any folks who haven't provided any feedback or thoughts that would like to do so? I just want to make sure I'm being tentative to y'all. Attentive.
Just coming from I work at Virginia Garcia, and coming from a PCP standpoint, I'm a peer support in Virginia Garcia, and I don't know, I think it would be helpful to that, you know, people understand that they can talk to um their PCPs about these kinds of things. You know, I think more and more they're starting to understand that, okay, doctors are getting a little bit more on board with this, and you know, if they need help, there is help out there that they can get connected to. And same with discharge planning. I think keeping helping them get being in recovery myself, helping them get into a physician following their stay, I think is really important, just so that they are kind of kept under, you know, just kind of watched over and make sure that everything is safe and sound. And if they do have issues, they've got somewhere they can go to and, you know, get things going. But that's from a, I don't know, from a PCP kind of standpoint.
Thanks, Becky. And I'm sorry, just one point of clarification. This section is just members only, but I do appreciate the community feedback.
Oh, got it. Got it.
Thank you, though. All right. So, actually, one other thing I just wanted to touch on for this thing, because I do want to be a little fair and not always feel like I'm being super critical of payers all the time. One thing I do want to throw out here is sometimes clinicians do make bad decisions in terms of like what should be recommended. And so like I want to be clear that this derived transition could be not necessarily a negative, but it is worth mentioning the why. My hope is that through kind of like quality improvement eventually, like that people are getting better at recommendations and getting better at tracking and all that. But it is a thing that I thought about, and the reason I'm mentioning is both in fairness, but also to think about this as like a potential TA need as we move along in the future, to be like, what's happening that's causing, maybe one area of the state to have a bunch of recommendations that just aren't flying, for example. So go ahead, Allison.
I appreciate you making that point. I mean, I think we're ACT, and I know we're not the only organization. I think, you know, as a SUD treatment provider, I'm always trying to combat the tendency to just count things. And you know, and to sort of rid our language of like, it's a 90-day program. It's like, well, for who and why? And so it's a good point you're making. I know it's a moment to sort of pile on because there's a lot of pressure on the other side to just like cut stay short because. And so I think there is, if we find a place for this, I think you're right, we have to be able to understand, not, this isn't a one-sided conversation.
True.
Or directional.
The next one was integrated support and continuity. So that was that plans reflect adequate, and these are the specific terms defined in ASAM. They're in last month's committee materials, but I'm happy to find them. Adequate, available, integrated, and sufficient supports. So basically, those are things that are either going to be clinical in nature or going to be natural in nature, and it's a varying degree. Transition and discharge plans are an extension of the treatment and care plan was a big thing that came up as we were talking about like where these are integrated. I think like I'm going to add the comma, potentially crisis plan, maybe. And then this has a cross-dimensional focus specifically related to those dimensional drivers of care, medical needs, behavioral health needs, social determinants, peer and recovery supports, harm reduction strategies, and crisis strategies to be able to kind of answer all of those various needs or service types that ASAM has said, like, you better at least be connecting folks to them. What's missing? How are you feeling about this is what you were talking about for integration. I am noticing that while I said medical needs, we didn't spell out primary care specifically. I don't know if we need to be very specific about types of provider or anything, but what are y'all thinking? Go ahead, Heather. I saw you were making space, but go ahead.
I'm making lots of space because I can talk a lot. Um, i- if there's any question, it never hurts to separate, because our folks do have urgent medical needs because their care has been delayed. So, if you want to say, both urgent medical needs and ongoing primary care, never hurts to be specific.
I'm imagining probably we'll have this like you saying that, Heather, makes me think that there's like a section that's like for maintenance of health versus like treatment of immediate needs or something that should be in here. Big topic of conversation that I will flag. I think this is going to take some skillfulness, I think, but and this is largely coming from like how a lot of treatment services are funded. But one of the things that we talked about was ensuring continuity of MOUD. There's a lot of work happening within our committee to do that. I think even in the conversation earlier around ASAM 4, you all like advocated pretty like strongly, and it's great to see that being a core theme of our work. But also this role of services to make sure we're connecting to the things that reduce risk of health problems or other safety concerns. And so I think that that's a question that I have to you of like, how explicit are we talking about the role of harm reduction in this? I think is going to be something that will be an ongoing debate, discussion, and probably require a little bit of delicacy or just to be delicate. But some of these things do not. And so I'm just curious, is there anything missing in here? Do we need to be more explicit about certain things? And this really goes back to, I think, the conversation earlier about like, there are things happening that you all know. I think our wonderful OHA partners in the chat were like, that shouldn't be happening under our current rule set even. And so like, what is it that like we're asking to change there? Go ahead, Christy.
I just wanted to say when we're talking about the justice settings and MOUD and all of that, there's a lot going on in that area, and there's a great echo training. I've done it twice now, and I think it's coming up pretty soon if I'm remembering right. So it might be something that if any of you are interested, because there, I mean, just between the two that I did, there was like 6 months in between, so much more has happened. And I'm sure this next round, there'll be even more. So if we can get those, just kind of partner up and know what the jails are doing and how we can, help set their priorities as to what we want our priorities to be, without telling them what to do.
Yeah, and that's one of the conversations that I have a pretty regular meeting with a couple folks in DOC, and one of the things that we talk a lot about too is like as jail MOUD is expanding, they tend to look to DOC for an example too. So like us reaching a greater consistency is like easier for their change management overall too, if they're not like doing a bunch of things back and forth. But also, to your point, leaps and bounds every 6 months, I feel like, too. Something that I'll throw out here that I was kind of thinking as I prepped these slides, in terms of this harm reduction and MOUD consideration, is I feel like there's an opportunity for either this to be considered a portion of our integrated support. I pulled it out as a separate theme just because it was such a heavy part of our conversation. So I wondered if it was there. I also wondered if it fell into this recovery management aspect, though, of like what are the things that you just need to like be a healthier person than you were the day you showed up to services today. So like I'll just throw that out there of like where does this role for like MOUD and harm reduction fit in the grand scheme of things, or is it truly that separate and we want to make sure it's called out as separate all the time too? Because I can see that being a benefit in either direction.
I don't know if this answers that question, but I honestly take a little bit of issue with MOUD getting lumped in with harm reduction. I've worked really hard to separate them. It has a harm reduction function to it, but
Yeah.
when I've come across people that more sort of intimately put them together, it has this like, well, if they can't do it the right way, then let's do it with MOUD, right? And that's changed over the years. That what I used to get. That was sort of all. That was the only way you could, for a long time, get people to accept MOUD. Was this like, well, I guess if nothing else works, and I really don't. I don't like it. I don't. It's not. So that's whether or not that was your question. That's my 2 cents in terms of where to emphasize MOUD continuity.
Now I think this leads to another fun question then too, because I'm glad that you said this, because the other thing that I've been thinking about in terms of where did that go? This recovery management relapse prevention tool part of this, right, is like when people leave services, I always like to joke around, hopefully for the final time they ever need them, but when people leave services, we tend to refer them to the things that help maintain those gains, right? And so one of the things that I'm thinking in here is, are we saying that, excuse me, because I'm trying to find the comparison here. MOUD is basically one of many evidence-based practices that treatment leverages to help people enter their self-directed recovery. And then what does that mean for harm reduction? So I'm just throwing that out here because we also have the recovery kind of part of our continuity of care and the prevention part of our continuity of care. And it makes me wonder like how we want to view those things as separate, because eventually my hope is we would recommend somebody to like a recovery center after they leave services so they can stay connected if that's something that they would want. So I'll just throw that out there. Like, are we wanting to look at this as like another branch of the continuum we are referring to? I know we're saying separating MOUD and harm reduction for a very different reason, but like, what is it that we're saying like in location to ourselves and the other parts of the recovery oriented system of care? Are we separate in the same way that you're saying MOUD is not necessarily harm reduction, though it has harm reductive benefits? I know that's a little weird, but hopefully somebody's picking up what I'm putting down. Go ahead, Heather.
I'm confused.
Okay, never mind then.
Yeah, I'm confused because for like I'm gonna be simple and just be kind of aligned with what Allison said, that MOUD is treatment and it's ongoing and it's healthcare, just like any other prescription that you have in your treatment of your chronic disease. So all those other things happen regardless or in addition to or at the same time or whatever you want to say. So if I was misunderstanding you, I apologize. But so to me, I'm going to go there, and then I kind of like the opportunity statement around what is previously known as harm reduction. Is that the way I have to say it now? Um, uh, I love stealing from Allison again the crisis planning metaphor, because then it's just what you need to do. Now I'm really going back to suicide prevention. It's what you need to do on the day that you make a decision. Because that might be, sorry for people who don't work in that field. You'd never ask someone what's your worst day, because that might be their best day. And so, I think that's a wonderful way to weave in the activities in a really meaningful way. Instead of saying harm reduction is what happens on that day when what do you have to plan for to keep yourself in your routine, because everybody's thinking about that anyway. I mean, we just need to talk about it, like everybody's thinking about that anyway. Maybe that's a way to frame up the language, because I know people nationwide are struggling with this and how to do it, but I think that could be a cool opportunity.
Go ahead, Christy, and then I'm gonna write a note so I don't forget that thought, Heather, because I have something that I think that gives another opportunity too.
I just wanted to piggyback off that when we were talking about discharge and how we want to be talking about, the contingency plan in case you do get exited from a program. What a great opportunity to be starting that at the beginning. What a therapeutic, I mean, you try to get someone to write a recovery plan, but if you do it this way, well, let's get this plan in place. You're writing the script, you're playing the tape, you're doing all those things, all those, catchphrases that need to start earlier in treatment. And what a way to do it without it being, let's do your recovery plan. It's more of a conversation. It's more ebb and flow. And it's webbed into everything that you're doing, just in case. And maybe people, if they have a plan, won't do the just in case. Maybe, it will help treatment numbers. I don't know. So I like all of this.
The thing that I was realizing that you're, I think, both describing in this also normalizes or kind of makes this more substance neutral also, because it doesn't become like, again, like the things that I think, like I included here, naloxone distribution, like those things, like those aren't unallowable activities. But one of the things that isn't called out in here is like, if you're gonna drink, can you make sure that it's not some place that you need to get into a car to do that, like all of those other conversations. So I think you enable us to have like a risk, like a truly like a risk reduction in case of relapse conversation in addition to, which is an interesting thing. I'm gonna pretend this slide didn't exist and I didn't lump those two things together, but also don't, because I'm glad that this conversation happened. um, recovery-oriented system of care alignment. So one of the things that this was somebody stayed on the call after and asked two questions, and they were like, number one, are we allowed to make rule recommendations? And I was like, we've done that already. Like that's what we do. But two, the other thing that they asked, they were like, where does ROSC show up in this? And that was something that like I was thinking a lot about. Like this wasn't a core theme, but it was a core theme in terms of like what you all hope to do. If y'all haven't read couple months ago, Allison and Lisa did a newsletter or an interview with us, and one of the things Allison mentioned at that point in time was like viewing what we hoped coordination to look like is like working like water, like we just open floodgates, people flow in the doors. And I found myself like when that question came about ROSC, like I found myself going, you know what? We are saying recovery oriented system of care. We run the risk, though, of making it all about us rather than making it about the system of care. Like, if we tell everybody, like, oh, we need to make sure that we get everybody to these programs and we do those things, I found myself wondering, though, like, how are we making sure we're describing the role if you have a client who's in a justice involved scenario? Like, what are those specific discharge transition plannings that you might need to continue if they're in foster, if they're in like in DHS involved services or whatever it is. So I'm just kind of curious, like, is there something that we need to kind of standardize here to make sure that people are offering a more like 360 or holistic view of care coordination? Because that's something that I know has been a struggle in the field. So I'm throwing that on there, knowing that it wasn't like a large part of the conversation, but we did talk about how hard it was to get all of those immediate needs. And I went to this place of, well, we did say recovery under system of care, which means working with a bunch of different types of providers. So it's been kind of lumped in there too. And then I would say like the second question is that solved by just a better fidelity to treatment planning? And because I think that's the other piece there. Go ahead, Mike.
I was just gonna say, I mean, even now we continue to see. I don't know. There's a part of me that's lately been a little bit discouraged with some of the decisions that we're seeing, even at the local level. With the transition planning work, is like, for example, Multnomah County and all the work that went into the jail system, and then that treatment team that was helping with transitions has been systematically cut every year now for a while, to the point where I know they lost their supervisor that was running the whole program, and the position was basically eliminated. So then it's getting put back into the way things used to be. So it's making it difficult, for people transitioning from the jail. I'm in a crisis treatment center right now. As we're working in the crisis treatment center, we have people come from the jail, they're on Suboxone, but they don't have a primary care provider. We can support the Suboxone while they're here with us, but then you have all these small entities then scrambling to find primary care providers for these folks, and that's a big gap right now. There's some providers that will take people with that are justice involved, but there's way too many that are not. And those are the same folks that we just find cycling through the system over and over. And I'm just not sure anymore what the solution is, because even in this space and in the larger committee, we have so many good solutions and so many big thinkers, but we're running into the same issues over and over. And I'm just kind of at an impasse at this point, just trying to figure out like, what do we do? We know how to, what the best treatment modalities are. We know and have identified so many of the gaps that are in place. But then the willingness of individuals to be able to take on, some of the most vulnerable and difficult populations, I think is what's really challenging. And so I don't know what we can do honestly in this space regarding that, other than to voice a need to incentivize heavily, taking on people from the vulnerable populations for providers and for treatment centers. I don't know. It just feels in many ways we've taken steps forward, but then from a ground level, we've taken some pretty big steps backwards. Because now treatment is available, but then there's no one to actually do the treatment.
I'm really glad you're bringing this up, Mike, because one of the things that I was sort of thinking as we've started this conversation around like standards, and this is like a weird anecdote to maybe use as the opportunity to bring this up, but I worked in a program that had supportive housing. And I remember one day we were like bringing somebody in, and the person who did their drug screening went, "Oh, they're positive. They can't move in today." And I went, "That's not a rule. Like, have you been acting as that it was a rule?" And so like I had a little bit of a conniption there. But one of the things that we kind of found out from that moment was there was an unspoken cherry picking of admissions that was occurring where people were kind of getting chosen based on like how likely they were to do well in the program versus how likely we were to be the best fit for them and their needs. And one of the things that I'm really kind of worried about as we start to be very specific around those standards is like, when does this accidentally become the new backwards thing? And how do we avoid that? And I think that you're speaking about this role of like, we started widening the role of care coordinators in counties through like ICC teams and doing all these different things. And as those have started to move away, programs like if we say like you're now needing to meet these markers for discharges and transitions, if people know that these populations like you're bringing up, Mike, are harder, like how do we avoid that cherry picking? And I like that's a big fear that I have as we start to do that. And I mean, don't say that in a like we don't do it, but I do think it adds a layer of complexity here of like the people who are going to need these transition and discharges charge planning the most are the people that are going to be the most challenging to pull them off, I think, as well, right?
Yeah, I mean you're right. I think that the cherry picking, that's a key word that you put there, because anytime people see aid and assist, civil commitment, jail, DOC, guardianship, then you're really starting to think, oh, let's look at this other person because there's so much in the way of need. And so finding guardrails around those populations, I think will be really critical to move the needle in what we're trying to do.
I'm gonna just make a note of like I have a feeling I know we've talked about a work product or an outcome of our committee and work group support is TA related to DOC related MOUD, but I'm just gonna kind of flag there feels like there's something that needs to be focused on here to kind of shore up that we're not um, moving backwards, I guess, for involving justice involved populations. I'm like struggling to like have that answer in one of these themes, but I feel like it's going to be something that maybe it's like a section of this that we really need to dial in, but behind it just being one bullet point or something. Which I believe, oh yeah, okay. Sorry, I'm just noticing time. I want to get through the themes and then just show you the big block of text. And then I think September we'll come back and do a little bit more on this and I'll have some recreated stuff based on your feedback. One thing that we talked about was the workforce and program support. So this is probably also linked to what Mike was just saying as well, but like having training for risk-oriented conversations. And I think this also goes back to this idea of this being a lot more similar to crisis planning. we're gonna have to get people more comfortable with dancing with like that day that maybe we don't want people to plan for, but need to plan for example. Strengthening an engagement and relational skill with counselors. I think that was one of the things I want to say Allison maybe had brought this up of like the conversation itself is the hard part even that we need to like get through is like how do we encourage these conversations? Um, in order to pull this off also like working to reduce program level denial rules, that thing that people says, oh, just keep calling every day and you'll get in, we'll have a spot for you, just keep calling or whatever it might be. And then the last thing that we talked about is just like, in order to pull this off, we have to figure out some sort of consistency for how CCO authorizations work because a lot of these services where those transitions are happening in the hardest places. Inpatient detox, for example, are a statewide resource. So you'll have somebody coming from Burns, Oregon to access something that maybe somebody moved one block away from to access on their own. And so figuring out how do we bring those together. The little images on the right, I went to just 2 random CCOs and looked at the same service, and those were what popped up for their authorizations for that. And that was really just sort of like a confirmation of what you all were saying. Not again, not a dig, but just to say like it is a thing. And as a on the patient end, this is what you would see if you were trying to figure out what your authorization would be immediately. Which is confusing to me as someone who even knows the thing. So I just wanted to flag that. Just moving through themes just so you all have them and can either email feedback or come back. There was this idea of needing to tie payment to quality of care. This starting to like talk through kind of levers of like what we're needing. So this is these could be documentation reviews or trying to figure out ways to shore up how CCOs and OHAs work together, for example. And evaluate the patient awareness of their own transition plans. I think this somebody had kind of jumped in when I had mentioned Dr. Melee's comment about if you go to your lobby and ask people what's on the treatment plan, if they can't answer you, are you doing well? Specific special populations that were brought up: youth, people experiencing incarceration or other justice involvement. So like now I'm sort of wondering, given that conversation that you had inspired, Mike, of like, are these like specialty, like other things that we need to do in addition to the standard to be going through? And then people receiving care in less resource-rich areas. I think that was a pretty common point of our conversation last month was rural populations in general are going to have a harder time with these transitions. So like, what are those considerations? And then here's the very messy draft thing that I threw together. And part of this is intentional because I don't think that a single block of text is going to fix this. If I had a magic wand, I would. But I think what I would encourage for folks to do over the next month is to really look at this definition and think about like where this is missing the mark entirely about what your intention was when we started talking through like what it meant to have a standardized discharge and transition plan. And then the next step is for us to break this apart after we've wordsmithed it perfectly and do all that and figure out like what are the actionable steps to get there. Um, Otherwise, I think we're gonna have this like cool like single page of what we want the system to do, but not know how to enforce that or how to like lead people that way. And so I think for us to get there, it's gonna take some discussion. But anything that's jumping off that screen immediately that people are like super angry about, I'm seeing Allison's face. I'm gonna pretend that that is like the most like pure satisfaction possible, but. But that was my like capture of last month's 90-minute conversation on it. So no, it's a lot. Okay, so we have 5 more minutes. I'm gonna turn to Ashley for public comment in just a second. But before we do, something I just wanted to check in on. I know that this is like year one of this plan is again a lot of us like researching and talking and doing those things. Something that I was talking to Annalise about, and this is, I'm not saying this to like butter y'all up, but a little bit to butter y'all up. It means a lot to me that y'all are like coming here and doing this every month because I know that this isn't the thing that like however long ago y'all got into the field thought you would be doing about hemming and hawing over like somebody's discharge summary that you'll never beat. And I think like if we can tie all these pieces together at the same time that ASAM 4 is coming along, like I think there's a lot of really awesome transformative things that we can do in this moment. So just thank you for like giving us your time. And on that note, Ashley, do you have any public comment?
We did not receive any written public comment today.
So does anybody have any public comment that they would like to offer, either verbally or in the chat? Okay. I'm anticipating, like I said, we did reach quorum. Thank you all. It was amazing how many August vacations popped up that weren't planned. And then I was in my head, I was like, I planned some of mine like a week in advance, and that's fun to do. So I'm glad that y'all are taking time. Next month when we come back, like I said, we'll have, I believe, a peek at the draft of our survey. We'll come back to talk more about standards and discharges, and then as Annalise mentioned, as we start to like get through the fiscal and assessment and everything, all of that compiled, we'll start diving in on that as well. And then also, I believe near the end of the year, we'll start to have another APAC poll. So there's going to be a lot of data coming into this space for us to start chewing on both things that providers have said in surveys, but also things that we can see in claims data and a bunch of other stuff. So if you like numbers, I'm excited for you. Anyways, thank you all so much, and I'll see you in a month.